Dr. Kast completed his pharmacy degree at the University of Munster, Germany. During his PhD, he collaborated with NASA to investigate the pharmacokinetic pharmacodynamic properties of medications during spaceflight. At the moment, he is a Clinical Pharmacology Senior Scientist at Amgen Inc. in San Francisco. Dr. Kast, you may start your presentation.
First of all, I really want to thank the organizers and really give them some credit. I think what I've seen so far and everything up front to this presentation is really outstanding, and I just want to give them some credit. This is a very well organized conference and very exciting. My presentation will be trying to answer the question, or at least provoke some discussion if there's a need for dose adjustments in astronauts during spaceflight. So when they have to take a medication, do we need to treat them in the same way that we would do on Earth, or is there maybe reasons where we have to consider maybe changing the dose? Before I go into it, I just, since I'm an employee of Amgen, I just have a disclaimer to mention. So the opinions I will share are my own opinions, and I'm not speaking on behalf of Amgen today. Before we go into it, I just want to give you like a very brief background about myself. You get an idea who I am and we are working with. So I'm a pharmacist, as already mentioned before. I started my PhD in PKPD at the University of Florida in 2013. I did some internship at Merck, and really where I got exposed to the spaceflight environment was with a different internship in 2016. It was actually under the previous speaker. She was my mentor and supervisor, Dr. Virginia Goldring. I learned a lot from her. And then that's where I really got introduced into the spaceflight community, and I did some research on PKPD of drugs in space. Then I finished my PhD in 2017, and really since then, I haven't done much in the spaceflight research field. I'm actually a clinical pharmacologist now at Amgen since 2018. And what I do in my current role is the development and safe and effective use of drugs on Earth, which is guided by principles of pharmacokinetics and pharmacodynamics. And I'll go a little bit more into it if you don't know what it is at the moment. But pretty much what the key goal is of my work is to guide the right and the optimal clinical dose and dosing regimens for different target populations. But target populations, sometimes you can, for example, talk about adults versus children and so on. And really those principles of PKPD, they guide the safe and effective dose selection on Earth. But those principles have not been applied in the same way to astronauts in space. To give you a little example, let's say COVID is of course still in everyone's head, still ongoing, and we have luckily the first vaccines approved now. But now if you want to give it to the children, which is kind of the next step, you cannot just give it to the same way without studying it. So what's happening right now, a lot of the companies that have approved vaccines, they're doing studies in children to really investigate if the PK/PD relationship is unchanged or not. And of course, if efficacy and safety is changed, and after you've studied it, then you can decide how you would administer it to children, for example, if you would need to change the dose or not. However, if you really look at the drugs in space and how they are taken, they're really taken under the assumption that the PK/PD relationship is similar in space as it is on Earth, but this hasn't really been studied much. And Virginia Goldring mentioned about several open questions remaining, and this is another one of those open questions that we don't have a lot of information. But let's just go to the typical label for any drugs, and it has nothing to do with spaceflight yet, but how does it work in the real life setting? So you can just look at any drug label in the US, for example, that's how it looks. And we always have some guidance about dosage and administration, how you should take the drug, and certain contraindications. And then another important aspect is always drug interactions and use in specific populations. I mentioned this earlier. Maybe you give it to children, and then in this example here, highlighted in yellow, sometimes it's the case that the dose in children is different than in adults, like for this drug. And this is usually caused by differences in PK/PD, as you can see here in the clinical pharmacology sections of the label. If you don't know what PK/PD means and what it stands for, I go briefly over it. Pretty much PK, or pharmacokinetics as we call it, describes what does the body do to the drug. So if you swallow a pill, the whole field really describes how the drug gets absorbed, distributed, metabolized, or broken down, and broken down and then excretes the body. And I think in our field, we talk a lot about those concentration time profiles that you can see on the right. And you give a drug, you can see if you swallow a pill, the drug concentrations rises until you reach this maximum concentration, which is called Cmax. And then it starts to be eliminated until it reaches the subtherapeutic concentrations. This whole area we call area under the curve. And those are both pretty important PK parameters. And what you're really trying to do if you develop a drug, you want to find a dose that is not in this toxicity range. So if you dose a drug too high, usually you have serious adverse events, which you of course want to avoid. But you also need to pick a dose that is high enough that you're in the therapeutic window, that you have an effective drug. Because if you don't, then you are in the subtherapeutic concentrations and then the drug doesn't do enough. Pharmacodynamics is the other partner. They come together, so PK/PD come together. And that can be described as what does the drug do to the body. I really like the example of antibiotics because I think it's pretty easy to understand. So it can also mean what does the drug do to the bacteria in the case of an antibiotic. And what you have here on the left is an image. Everything that is yellowish or whitish on this agar plate is bacteria. And you have those different plates here. And those different plates are infused with different concentrations of a specific antibiotic that is against this bacteria growing here. And you can see from left to right, you give or infuse these plates with increasing levels of antibiotic. And once you see the growth of the bacteria is inhibited, like in this case here in the red box, that's really where you identify your MIC. That's just a measurement. And then usually the effectiveness of the antibiotic is a function of its MIC. So the higher the MIC is, the less likely it is for the antibiotic to actually kill the bacteria. Again, I talked about this earlier. We do dose adjustments in special populations all the time. In fact, if you develop a new drug, that's part of the research you have to do. How would you give the same drug in elderly, for example, in pediatrics, in children? Certain drugs metabolized and excreted by the liver or the kidney, and you would have to dose adjust for individuals that have, for example, organ impairment. And then really the question I want to discuss today, well, is there a reason to maybe dose adjust in astronauts as well? So before we go into this, I mean, this kind of follows up on the previous presentation, but I think, which was a very nice overview, I thought. What really you can see, or what you learned already, that medication usage is very frequent actually during space missions. This is a little bit of a different illustration. It just shows you how many % of the crew members use a certain drug class. And you can see here sleep promoting drugs are very frequently used. Approximately 70% of crew members use those drugs. But then you can really see, in general, I think we can see that medications are taken relatively frequently on the International Space Station. I think one question that is important for us is how effective are those drugs in space? And Virginia touched on it a little bit, but this is a very nice illustration of different drug classes and how effective they have been reported. This is all subjective, based on subjective evaluation. So not the ideal measure, but it gives us some idea. So we can see here, it seems like the stimulants seem to be pretty effective based on this research that was done. But then we have certain drug classes where at least it was reported that certain drugs were only somewhat effective, or even there were some reports of ineffectiveness of some of those drug classes. In general, it can be said though that the efficacy of medications is not very well documented, and a lot of the times it relies on the subjective measures. And Virginia touched upon it as well. Those things are not necessarily well documented. And as she mentioned, there was certain underreporting of the drug use before she did this study. Of course, I think it's pretty clear. If you think about the spaceflight environment, it is very different from the environment on Earth. Gravity is, of course, one of the most also factors that kind of stands out. But we also have radiation on the ISS. It's not as high, that's true, but it's significantly higher than on Earth, and the exposure that is. But if you go further away, it gets even higher and higher. So if you go to Mars, the exposures are really getting significantly higher than what we are used to. And then, of course, we have the confinement, high-stress environment that we have on the space station. And really what it does, it really impacts every organ in the human body. And pretty much the human body changes a lot and adapts to the spaceflight environment. Some of the things that really I want to discuss today, because they could impact how drugs work and are effective, are, for example, kidney filtration rates. They increase. A lot of drugs are excreted by the kidneys. We have this fluid redistribution from the legs to the face. That was also discussed earlier already. We have several other changes as well that really could impact how drugs get absorbed, metabolized, excreted, and how they work. Again, this is kind of a different illustration about the same concept. We have all this stressors from the environment, like radiation and others on the ISS that the astronauts are exposed to. And then those things can really change how the PK/PD characteristics of drugs might behave. So if you just think about it, you swallow a pill on Earth, and what happens? It kind of, you swallow it and float on the gastric fluid, but in space, that might not necessarily be the case because of the microgravity environment. So there's a potential of a change in gastric emptying time and also intestinal enzyme activity, for example. So absorption can be different. There have been some studies that actually showed that distribution of drugs in space could be very different. We have this whole remodeling of the human body, I almost want to call it, and loss of bone mass, muscle mass. And this could really impact how the drugs are distributed in the body. Certain drugs are distributed into the tissues, into the muscles. And if this whole relationship changes, this could really impact also the PK of drugs. And then, of course, metabolism, excretion. I touched about this earlier. We could have differences in enzyme expression, for example, of the metabolic enzymes, organ perfusion, the things that come to mind. Now let's look what has been actually done in regards of PK/PD spaceflight studies. And this is really, if you look at this list, it's very short, and a lot of the data or findings that I reported here are actually based on anecdotal reports or analog studies. And a lot of those analog studies haven't really been validated in space. So we're doing them under the assumption that they'll tell us what happened in space, but we really have never done like a thorough comparison to really confirm that. And another thing that's really important to note here, a lot of those studies are really not PK/PD studies, they are just PK studies. So we don't really know what happens on the PD side. Just to kind of summarize this a little bit and also transition to the next part of my presentation. And we heard this earlier, that sleep drugs are very common, and there have been reports in the past that some astronauts have taken multiple doses of sleep drugs, or they have combined different sleep drugs in the same night, something you shouldn't do. That at least suggests that maybe the first dose may not have been effective enough. We have seen some reports of non-efficacious treatments. I also showed you this image. There's some literature that mentions this as well. And of course, we really need to think about longer duration missions as well, as the risk of a medical emergency will increase with longer duration missions. And it's pretty difficult to really know how to treat the astronauts and if we really need to adjust the dose or not, because we have very limited data collected so far. So first of all, as Dr. Votring already showed you, there's very limited data out even how medications are used and taken during the spaceflight. There's more research being published now, but it's still pretty limited. It's even more limited when you look on how those medications work during spaceflight, and if you want to really dig into it, if the PK and PD properties of those drugs have changed or not. And the majority of the generated data, if it's generated, really lacks adequate control groups, relies on subjective assessments, or relies on analog models that have not been adequately validated. Again, if we plan to go to Mars, the risk of emergency increases, and I'm specifically concerned about serious medical events here. So I think a headache can be pretty severe and bothersome, but most of the time we can deal with it. We can treat it with pain medications, for example. But what if something more serious happens, for example, like an infection in space, a bacterial infection that could be potentially life-threatening? It's known, and again, you have seen this in the previous presentation, that spaceflight induces a reduction in immune competence and immune response. So the immune system doesn't seem to work as well in spaceflight. Of course, that's a concern for infections in general. If we go further away from Earth, really, you cannot evacuate astronauts anymore. At the moment, at least, you could do it if you would absolutely have to. And infections during spaceflight actually occur relatively frequently. If this 10 period between 1989 and 1998, in the space shuttle program, 26 cases of infections have been reported in American astronauts, something that certainly happens. I mentioned the radiation activity during spaceflight. And of course, when you think about radiation, I think one thing you can immediately think about that the mutation rates could be higher for those bacteria in this environment, which could potentially lead to antibiotic resistance and mutations. And if you look in the literature, there's really mixed evidence if maybe the bacteria in space could be more virulent or not. Some literature even suggests decreased virulence in space. But overall, it's not well understood what happens, and it's even less understood if the current antibiotic therapies that we use on Earth are effective in the same way in spaceflight. So again, if you want to think about this, especially again, if you want to think about infections in space and what could be really causing or contributing factors that could make them consequential, as one of them is the drug stability. Again, something you've heard in the previous talk. So potentially our drugs are less stable in space, or even if you go on long duration missions, you might have less active drug over time. We might have an increase in antibiotic resistance, for example, through increased mutation rates. We could have, or we already know that the immune response is reduced, and during spaceflight, the immune system doesn't work as well. And then we could also potentially see a change in PK/PD response. Again, we don't really know much about this topic yet. So really the question is, are Earth-based dosing regimens effective in space or not? Should we give the same dose to the astronauts when they're in space? I want to present you some data today where we tried to at least answer part of this question, and did a little experiment that was done at our lab a while ago. And we really tried to do a PK/PD study for antibiotic with the name of ciprofloxacin. And the way we did it, we evaluated the PK of the pharmacokinetics of the subjects in the so-called bed rest study model. So you put a subject here on this bed rest and you tilt the bed downwards so you can observe certain fluid shifts, which try to simulate what happens during spaceflight. And then you measure the PK in the simulated microgravity condition in a control condition. At the same time, we also measured the pharmacodynamics. So in those vessels, we would put a certain bacteria, and those vessels actually rotate. So this simulates the microgravity environment in space, and you'll give, again, antibiotic at different concentrations. And you see how those bacteria grow over time with different concentrations of antibiotic. And then we have a control condition here, which in this case, the vessels rotate, but in a different direction that doesn't really produce the microgravity scenario anymore. And then we really tried to put this together to see if there's a difference in PK/PD or not. Let's just look at the PK data. Again, this is for ciprofloxacin, an antibiotic, and we look at the PK in 0G and 1G. So if you just look at the plots here, you can actually see that it seems that there is increase in concentration and the Earth's gravity versus the simulated microgravity situation. It's not very severe, but it seems to be at least a difference there. So this is just based on the PK. Now let's look at the PD. And again, what you can see here, we call them growth curves under different concentrations of antibiotic. And you can see the different panels. We start from the left, the control curve that does not have any ciprofloxacin in it. And we can see how the bacteria grows over time in 0G, which is microgravity is the red curve versus the blue curve in 1G. And you can actually see that at the control group also, as well as at lower concentrations of antibiotic, that it seems that the bacteria seems to grow better, or you can achieve higher concentrations versus the 1G scenario. And this is really consistent across the lower concentrations until you reach a concentration of 1 times the MIC. And then at higher concentrations of the antibiotic, really there's no difference in killing anymore. And you can describe those relationships with the equation. I don't want to go into the details, but pretty much you can use this then to simulate different dosing regimens to see if your dosing regimen is adequate enough to kill the bacteria in a patient. And that's pretty much what was done here. I'll guide you through this. On the left, you can see the situation in 1G. So again, here you simulate a dosing regimen you would give to a patient, for example, 500 milligrams twice a day, which is an improved dosing regimen. For ciprofloxacin, you kind of see how bacteria grows. Let's start looking at the growth control first, which is the red curve. So you don't give any drug. It's kind of just a repetition of what you've seen in this previous slide, just presented in a different way. But you can kind of see, of course, if you don't have drug, the bacteria will grow until it reaches a certain threshold. And you can see here the simulated ciprofloxacin concentrations in the background and how quickly this will be able to kill the bacteria. And you can see in this case that the bacteria starts to get killed very quickly. Within 12 hours, the bacteria is gone, pretty much telling you this is a very effective dosing regimen. And this drug is, ciprofloxacin is good against killing E. coli in this setting. Let's see what happens in the microgravity environment. Again, let's start with the growth control curve, which is the red one. As you saw earlier, at low concentrations, you can see that the bacteria is able to reach higher concentrations and Again, if you just look at the concentration of ciprofloxacin, and if you remember from my earlier slides, the observed ciprofloxacin concentrations in the microgravity scenario were actually slightly lower. But then how does it translate killing of the bacteria? Actually, in this case, it really doesn't show much of a difference. In both scenarios, the killing of the bacteria is relatively quickly. So in this case, although we saw some differences in PK and PD individually, when you put them together, it didn't translate to differences in the killing of those drugs under those conditions. So in the clinic, you would not have to dose just for astronauts in space based on the specific results. Just to conclude this part, although some differences in PK and PT have been observed for ciprofloxacin in Earth's gravity and simulated microgravity, they did not lead to a major differences in killing of E. coli. In this case, the dosing regimen of ciprofloxacin was adequate to treat infections of E. coli in Earth's gravity or in simulated microgravity. Based on these specific results, it doesn't appear that there would be a need for dose adjustments for astronauts during spaceflight. However, it's difficult to generalize the findings, and also those findings that I just presented rely on space-like analog models, which in my opinion are not very good, and we don't really know how well they translate to the situation in space. In my opinion, we really need to have some in-flight studies that measure the PK and PD of drugs during spaceflight in astronauts. Why do I think the bad rest models are not necessarily, or like this analog models in general, are not necessarily ideal to simulate the differences? Because they cannot simulate the complete spaceflight environment. I think that's pretty obvious, as this environment is so different. So some of those similarities are, for example, like you can see some of the muscle loss and bone loss and fluid shifts, but of course you don't really have truly microgravity level. You can't really simulate the radiation levels. And also I think the stress that really can also change several things within the body. Just to sum it up, the spaceflight environment could significantly impact the safety and efficacy of drugs if PK and or PD properties change during spaceflight. Currently, it's really not well understood to what degree dosing regimens used during spaces are appropriate to guarantee safety and efficacy of administered drugs. And we have some evidence astronauts take those drugs. We know that they somehow work. If they wouldn't work at all, we would know. And there was some research that I showed you, but really there's not a lot of data out there. Changes in the PK and PD of drugs could be associated with increased adverse events or therapeutic failure. Both scenarios could threaten crew health, especially in long-duration missions into deep space where fast return to crew to Earth is impossible. I really want to conclude this talk now with one of my favorite quotes, and that comes from a Chinese proverb, which says the best time to plant the tree was 20 years ago. The second best time is now, and I kind of slightly modify this quote to the best time to conduct an in-flight PK/PD study in astronauts was 20 years ago. The second best time is now. With this, I want to thank everyone for the attention, and I'm happy to answer questions, I think, after the next speaker.